Okay, so just a quick reminder for you guys that first of all, these videos are for you for this term. They are not to be circulated elsewhere. They are not to be downloaded and kept beyond that. And again, as I explained to you guys last week during the first class, we're going to be doing this term as you're going to have these videos which are going to have what I would normally cover in lecture in class. I will pause at various times because you will have links to either articles to read or videos to watch. And I'll also pause at times for those reflection questions. So again, as I said last week, throughout each of these videoed lectures, there will be some reflection questions. Sometimes it'll be one, sometimes it'll be two, sometimes it'll be three. Just depends on the content and how much there is. They are not at set points, so I can't tell you, oh, just fast forward 5 minutes and 27 seconds and there's the first reflection question. You just got to bear with me, listen to what I have to say, get to the reflection question, and remember to email the answers to those to me before class begins. And that way you guys will have had the lecture component, you've had a chance to think about the content, and when we meet online for our discussion, we are all actually ready to discuss and learn from each other. It's weird. It's not the way any of us wanted this semester to go, but it's what we're doing, so we're going to roll with it. And I'm going to start with your least favorite topic. Inevitably, by the time you get to a fourth year psych class, you don't want to see the words research methods appearing on a screen. But what I'm going to focus on are some concepts that are more important for abnormal psych and clinical psych that you may not have gotten as much exposure to in other classes. So some of it will be repetitive, the first couple of slides, but I like to make sure that we're all on the same page, and then we'll get into some of the stuff that actually applies a little bit more for abnormal. I'm also going to acknowledge for a moment that this is incredibly weird that I'm standing in a room with one person. Caleb Zarn from the Academic Media Group is here filming today, and this is really, really weird. So bear with me, as it is what it is. So here we go. We're going to start out with some of these important concepts. And again, we always have to start with, okay, what exactly are we doing? Remember that as much as psychology is a bit of an art, it's also rooted in science. So we have to make sure that when we are conducting research studies, and particularly when we're conducting research studies for treatment, so what we would typically do in the clinical area, it's really important that we try to stick to research methodology as well as we can, because that's what tells us that it's working, okay? And we kind of need to know that. We need to know what does work and what doesn't work. So, of course, the first thing we have going on is our hypothesis, our expectations of what should occur if a theory is correct. So we don't just, I can't just wake up in the morning and be like, oh, I have this great new idea and I'm going to try it in therapy today and it's going to cure depression. It's not going to work that way. I need to actually think about, why do I think this great idea is going to work? What am I specifically going to test? And what am I going to test it against, which typically would be whatever the current gold standard treatment for depression is, which tends to be cognitive behavioral therapy. And then we can make those predictions and see what happens. So we need that hypothesis to get us started. What we also have to remember is that we cannot prove theories or hypotheses. So again, we gather data to support or refute them, but we can't prove them with absolute certainty. We always have that degree of chance that what we're seeing happening is occurring due to chance variables. We're generally pretty happy with that probability level set at 0.05, but keep that in mind. So when you are writing answers to questions for me or writing a paper, never, ever, ever say this proves the hypothesis, because I will basically tear your paper with my pen or tear my iPad with my Apple Pen, crossing out the word prove, because it just really irritates me. So please keep that in mind, okay? And of course, a good theory is going to be both testable and specific. So we have to be able to test our theory. We have to be able to see, are these variables actually related? Are they doing what we think they're supposed to be doing? And it should be specific enough to say what will happen if our theory is correct. We don't have to know what will happen if our theory is incorrect. It's helpful sometimes, but we should be able to be specific about what is going to happen. Okay, moving right along, next important concepts are two that you have heard about many, many, many times, but of course we're going to go there again: internal and external validity. So again, when we're talking internal validity, it's the extent to which the experimental effect can be attributed to the independent variable. The independent variable, of course, is the variable that we are manipulating. It's what we're controlling, and it's what we want to see having an impact. So if we could think back to that example from just a minute ago, that I have this new great idea for curing depression, what I'm going to be manipulating, my independent variable, is going to be treatment modality, where I'm going to have my new fabulous cure, and I'm going to test it against cognitive behavioral therapy, which is the gold standard. And if I'm correct, and mine is a cure, people in my therapy group will do better than people who are in the cognitive behavioral therapy group. So that's for our internal validity. We want to know that we are manipulating our independent variable, and that is what is responsible for the change that we're seeing. We always need a control or placebo or no treatment group to establish internal validity. So again, that example, I have my new cure, I have CBT, and then I'm going to do what we often do in clinical research and have what's called a waitlist control group. And the reason we do that is it's not really fair to say to someone, hey, I'm recruiting participants for a study for a new type of therapy for depression. Do you want to be in it? And then they sign up and you're like, yeah, okay, you're not getting any treatment. That's really kind of not so ethical. We're going to talk about ethics next week, but we have to keep that in mind. So what we often do in clinical research is we'll have what's called a waitlist control. And so let's say the treatment protocol is 12 weeks. So people would come in for therapy every week for 12 weeks. At the end of the 12 weeks, we assess. We see if they're doing better or not. What we would end up doing in order to have this no treatment group or this control group is we would have a group of people who would say, listen, right now all the therapy slots are full, but I can put you on a wait list, and when a slot becomes available, you can start your treatment then. As the researcher, I know that that's going to be in 12 weeks. The client doesn't know that. They just know it's going to happen sometime. And what we're able to then do is see what would happen with no treatment over that same 12-week period. Some people may show slight signs of improvement, oftentimes with something like depression. Once you have committed yourself to getting some help, things start to get better even without that help. But what we should see is a bigger difference in the treatment groups than the waitlist control. And then, of course, because it's unethical to tell people, well, we'll put you on a waitlist, and then at the end of 12 weeks say, oh yeah, no, study's done, bye-bye. We then do give them treatment at the end of the 12 weeks. We give them the full 12 weeks of treatment then as well. And that's how we're able to establish a no treatment group in a treatment study and still be ethical about it. So that's an important thing to keep in mind. External validity, on the other hand, is the extent to which the results of the experiment can be generalized. So one of the problems that we sometimes have is things work really well in a super controlled lab setting. And so again, I'm just going to keep coming back to this example of depression. I don't know, maybe the effect of 6 months of lockdown has me thinking depression all the time. I don't know. But thinking about when we do a research study using depression as our key variable, what we're interested in studying, typically we'd have pretty strict exclusion criteria and inclusion criteria for the study. So somebody can only participate in the study if they've been diagnosed with major depressive disorder, they don't have any manic symptoms, they don't have a comorbid substance use issue, they don't have any past major trauma or signs of PTSD, they have to speak English as a first language, they might have to not be taking any other medications, and definitely not any antidepressants. And so the question is, who in the real world is like that, right? Because in the real world, depression is messy. Depression can result from trauma. It can be a factor in substance use disorders. People can be using medication to treat their depression or taking medication for other issues. So even though my new miracle cure might work great on this select group of depression unicorns, we're going to call them unicorns because people with just major depressive disorder with nothing else going on, they're pretty much unicorns. So this works great on my major depression unicorns, but on regular people with depression, it's useless. I don't have external validity at that point. So internal validity is crucial because it tells us that our independent variable is responsible for the change, but external validity is also really important because we can't just have things work in a lab or a controlled clinical setting. We have to have things work in the real world as well. But if I was picking one to say one was more important than the other, definitely internal validity. Okay, hopefully you're not too bored yet. Even if you are, you got to keep watching. There's a reflection question coming eventually. So we go on now to statistical versus clinical significance. And I also have some coffee. This really is just mimicking real life experience, guys. This is how it would be in the classroom, I promise. I'd be drinking. There might be something in my coffee. That's for another day. We don't talk about addiction in this class for a reason. No, okay, moving on. See, the jokes don't work as well with an audience of one. It's just, is what it is. So you, of course, as fourth year psychology students have been hearing, fourth year, fifth year, sixth year, seventh year, whatever year you are. The point is you're here in a fourth year class. You've heard a lot about statistical significance in your research methods classes, in your intro classes, in all of our 2000 level classes in psych. You've heard about it. And so we know that statistical significance means the result has a low probability of being the result of chance factors. Fantastic, great, wonderful. We can go publish our paper. We can get our grants. We can pat ourselves on the back and feel great about it. But, there's always a but. Statistical significance is not always going to be meaningful. And that becomes a pretty big issue in the clinical realm because we're often dealing with small sample sizes. So one of the things that happens, we know that the GRE, the graduate record exam, the exam that some of you are dreading taking or are now shivering with fright because you are having flashbacks to when you wrote it, we know that the GRE is correlated in a statistically significant manner with success in first semester of graduate school. So that's why universities continue to use the GRE as part of their admissions package. The thing is, they've arrived at this statistical significance with hundreds of thousands of scores. So it's not actually a terribly strong correlation, but it's statistically significant. Is that actually meaningful? Maybe, maybe not, right? Some people are just, and I've heard this from so many students over the years, are just not good test takers. Does that mean that they shouldn't have an opportunity to try grad school? And maybe they could be wildly successful because they are passionate about their content area. But some gatekeeper somewhere said, nope, you need to get X score on the GRE or higher because that's statistically significant. But that might not be meaningful. And that's where we get into the world of clinical significance. Because in clinical studies, we're often dealing with much smaller sample sizes. We can sometimes only have 10 participants per group. We can even have fewer than that, depending on what sort of treatment it is, how novel it is, and how rare the disorder is. So sometimes we have to look past whether we're at the 0.05 level of statistical significance to see if we actually have something more meaningful, okay? And so this is where we get into this idea. I do this in real life class all the time too. I talk about something before putting the point on the screen. This is what happens. Okay, this is really real. It's starting to feel really real because like I'm doing the same stuff. Okay, so I already said this. It has to do with whether the effect is meaningful in treatment. That's the other thing you guys will notice. I'll talk about something and then I'll look down at my notes and be like, oh yeah, I already talked about that. So we go on. I wasn't sure if the videos would feel authentic. It's feeling authentic to me. Caleb's sitting here nodding his head, so I guess it's kind of real too. The other brief thing we're going to talk about, because this comes up more in the literature, so when you're looking at research studies, when you're reading journal articles, which I know you all love doing in your spare time, particularly with clinical studies, you might come across the term effect size. And so when we're talking about the effect size, we're talking about the amount of difference among members of a group in a clinical study. Yeah, and if your head is going like, we're basically trying to apply statistics to clinical significance. That's basically what effect size is, in a nutshell. Okay, so it's a statistical way to compare groups on clinical change. Or, as I wrote in my notes, a way of statisticizing, because I like to make up words too, clinical significance. So that's one of the things to keep in mind. I'm not saying that in the clinical world we dismiss statistical significance. We don't. It is still important. And it's particularly important for publication of research articles and for obtaining research grants. Not going to lie there. But sometimes we have to look beyond the p-value to look at meaningful change. So to give you a more clinically relevant example, the Beck Depression Inventory is a tool that we use a lot in clinical research to rate depression. It's a pretty quick paper and pencil questionnaire. People rate how they've been feeling along various symptoms of depression over the past 2 weeks. And then we're able to see over time if their scores on what's known as the BDI change. Now, if I have enough participants in a study, and so again, I have my new super cure for depression, I have my CBT group, and then I have my waitlist control group. If I have enough participants in each group, I might find that there is in fact a statistically significant difference on Beck Depression Inventory scores between my Miracle Cure, CBT, and waitlist control in that order. So Miracle Cure has the biggest change, CBT, and then waitlist control. And so from a statistical point, that lets me say, yay, Miracle Cure is awesome. However, if I look at the actual numbers, and there's a 1 point or 2 point difference between Miracle Cure and CBT, that is not going to be clinically significant, right? If somebody goes from feeling down most of the time to a lot of the time, that does not mean their depression is gone. They're still dealing with significant symptoms of depression. And so that's where we have to dig a little deeper and read a little further when we're looking at clinical stuff, because I might get statistical significance, but it might not be clinically meaningful. Similarly, if I don't have a lot of participants, I can have a 10-point difference in Beck scores between my Miracle Cure and CBT. But without enough participants, that might not reach statistical significance. Does that mean we throw Miracle Cure out? Of course not. It means I patent it, trademark it, and then try to test it with a larger group of people and make a lot of money. So yeah, I'll just keep teaching for now because that's where that's going, okay? But so does that make sense to you guys? Of course you can't answer me, so I'm gonna go with yes. And if not, make a little note, bring it up in discussion. So that's another thing, and I will have probably talked about this last week when we were live, but just in case I didn't, as you're watching these videos, you can pause at any point. You can also write down or email me a question while you're watching it, and then we can make sure we deal with it in discussion or one-on-one. So keep that in mind. Okay, moving away from this, we're going to now get into studying individual cases, which also is probably something that you have not thought a lot about or learned a lot about, because in so many psychology classes we're concerned more with the sample size, the population, the differences between groups. We don't think about individual cases as much, and we tend to be sometimes a little bit dismissive of like one-offs, right? Well, that's just a one-off. Except in clinical research, sometimes we have to go to the individual case, because sometimes we're dealing with a disorder that is quite rare, or we're dealing with a pattern of symptoms that is quite rare or quite different, or someone has multiple diagnoses that are not typically seen. And so in those cases, we start using what's known as the case study method. Now, here's where earlier I said we have to remember that psychology is a science as much as it's a bit of an art. When we get into case studies, we're dabbling into the art side a little bit more. Sometimes clinical intuition becomes quite important as we're working through these cases. But essentially, when we're conducting a case study, it's a really comprehensive record, detailed information about one person at a time. And case studies are helpful for rare clinical cases and new methods of treatment. So someone one day thought it was a great idea to throw electrodes on a person's brain and flip the switch and send jolts of energy through them. They didn't try that on 100 people at once. That was one person to start with. And some other things. Lobotomies are another thing that came up as a result of one person, and then it got more popular. So when we're introducing new and sometimes radical treatments, As an aside, lobotomies are no longer done, but cingulotomies are, so they're much more precise, but there are challenges with them. And electroconvulsive shock therapy is actually still used very much today. It's a lot more humane and it's still not the most pleasant thing, but it's a lot more pleasant. People are sedated, they're given medication, they don't remember it happening because it happens under anesthetic. So it is very different than what you saw in One Flew Over the Cuckoo's Nest, I promise you that. Okay, Caleb looks a little relieved now. Okay, so when we have some new ideas for treatment, when we have rare cases, that's where case studies might become important. So again, we see how the statistical significance becomes less important, because obviously with an N of 1, we're not going to have statistical significance, but we're looking for meaningful change. And towards the end of this video, we'll talk a little bit about how we can actually assess when we only have one person. Now, the other thing I want to say about case studies before I move on, even though I already flipped my notes over, is to remember, you guys are going to be writing up a case for your case study assignment. So you want to really remember that comprehensive part. When I'm reading a case study, whether it's published in a journal or whether it's written by a student for this course, I want to feel like I know the person, that I was the therapist in the room interviewing them, even though I wasn't there. That's the type of level of detail. I don't need to know what they ate for breakfast. I don't necessarily need to know their favorite color unless that plays into their symptoms somehow or their disorder somehow. But I need to know what their family life is like, what their family life was like when they were younger. Do they currently work? What do they do at work, right? How do they get by on a day-to-day basis? What are they struggling with? What are they successful with? All of that goes into a case study to help us understand the person and understand either the disorder or the symptom presentation, or sometimes why they're treatment resistant. Right? There are some people who just don't respond to treatment. It's not that they are saying, oh no, I don't want treatment, but we try treatment after treatment and they don't seem to get any better. That's when delving deeper can sometimes be really helpful. And that's where case studies come in. Okay, we're going to move on to my favorite statistic. And I realize that sounds weird, but I tell students this every term. When you've taken as many stats classes as most of us have as faculty, at least in psychology, we tend to develop favorites. We don't have favorite students, of course. Well, maybe a couple of you, but I'm not going to talk about that now. But correlations, I've just always been drawn to them. I find them so interesting. I find it particularly interesting how we can have things that maybe don't make a whole lot of sense that actually are correlated. That's kind of fun. So yes, if I were like on some sort of quiz show and they were like, what's your favorite statistic? I have an answer. It's correlation. Weird random facts. Now, of course, the problem with correlation is the problem of causality. So in other methods, in other experimental methods, we are looking to determine cause and effect. That internal validity that we talked about earlier, where we're looking to see that our manipulation of the independent variable is what caused the change in the dependent variable, that's causality. With correlation, we don't have that. We simply know that two factors are related, and we can guess as to why, but we can't be certain. So correlation does not allow you to establish cause and effect relationships. It only, oh, whoops, no, I took that point out. See, this is what happens. So it only allows you to say that when one variable occurs, so does another, but there's no explanatory power. And then the other problem that we come up with is the third variable problem. Two factors may be related, but it could be because of a third factor. And so what I'm going to have you do at this point, you'll see in your slides now, there's a little link here to a BuzzFeed article, because I go to the most precise scientific academic material out there. Yeah, okay, no. But I like to go to stuff that makes things a little more relatable sometimes. I also like to think that somehow that keeps me like a little bit younger, maybe not, I don't know. But anyway, click on over to that, and that will tell you 10 of the most bizarre correlations. So go ahead and do that. Hit pause on me right now. No, really, stop me. Okay, and now maybe you're back. Maybe you've had a chance to look at those. And now we have our, whoops, oopsies. I have a point and then I have a thing. See, I told you I'd make mistakes, guys. It happens. So correlation is used to establish whether two variables are related without manipulating an independent variable. I think I pretty much already said that, which is why I was like, oh wait, there's another point here. So here are reflection questions number 1 and 2. So this will be another place where you want to hit pause after you've looked at these, and you can jot down your answers. Of the correlations described in the BuzzFeed link, which is the most ridiculous to you and why? And I can guess which one you guys will probably find quite ridiculous. And then of the correlations described in the BuzzFeed link, which do you think you could present to a family member and they would believe it to be true? Now again, remember that all of these correlations are actual, true, mathematical, statistical correlations. But every single one of them is related to some third or fourth or fifth variable. But which one do you think you could present as if those two factors are actually related to each other to a family member and they would believe you? And tell me why. Yeah, I'm gonna make you think a little bit, guys. That's kind of the whole idea with these whole reflection questions, thinking. So again, remember, you have to email your answers to the reflection questions to me before class begins this week. So go ahead and pause, answer them. This is also probably a good time to mention that the PowerPoints that I put on Blackboard for you do not contain the reflection questions. The only place you're gonna get them is on these videos. I'm sneaky. Those of you who've had me before know that. It's what it is. Okay, I'm going to assume that you're unpaused at this point and coming back so we can keep talking about correlations. So how do we measure correlations? Well, we get out a ruler. No, we don't get out a ruler. We don't do it that way. But we measure based on two factors, the strength or the magnitude and the direction. Okay, and I find for some reason, and again, because correlations are like my favorite, they're my baby. Well, my child would probably object to me saying that, but it's one of these things where I'm like, no, but like it totally makes sense. But I find that students often struggle. So I'm gonna go through it again. And if it's repetitive, well, just tune me out. I don't know, go click over to TikTok or something while I'm doing this and then come back. So when we're talking about the strength of a correlation, we're talking about the absolute value of the number. It ranges from 0.00, which is no correlation, all the way up to 1.00, which is like totally strong. Every time this thing occurs, this other thing occurs, okay? So I'm gonna just take, as an example, brown hair, brown eyes, because quite frankly, I've got brown hair and brown eyes, and why not make it all about me? We know that oftentimes people with brown hair have brown eyes, but not always. Sometimes people have brown eyes with blonde hair. Sometimes people have brown eyes with red hair. Sometimes, in the case of my husband, people have brown eyes with no hair. Just kidding, he doesn't have brown eyes. He doesn't have any hair, but he doesn't have brown eyes. So we know that brown hair and brown eyes are strongly correlated, but it's not perfect. So if you were talking to someone online, because who meets anybody in any other way these days, right? Like, well, especially now with coronavirus, you can't go to the bar and meet someone. And if you do, they're behind a mask. You're like, do you have all your teeth? Like, what's the deal there? So they're describing themselves and you say, what color are your eyes? And they say brown. And you might think, oh, so there's a pretty good chance that they have brown hair because that's a fairly strong correlation. And they may very well then say, yes, I do have brown hair, but they might surprise you and say that they have blonde hair or red hair or gray hair, okay? So it's not perfect. That's the strength of the correlation. The closer the number is to 1, the stronger the correlation. This is where I get ahead of myself. And then it's the direction is the other piece. And the direction is what tends to trip people up because the direction can be positive or negative. But in this case, you have to really remember, and the reason on the slide I actually put this plus sign and this minus sign is that we have to remember that that's actually key. When we hear positive, we think good. And we hear negative, we think bad. But these are not value judgments. Nobody's judging correlations here, okay? We're not judging the strength. What we're saying is either the two factors move in the same direction or they move in opposite directions. So in childhood, Height and weight are positively correlated. Typically, as a child is growing, they gain weight and they grow taller, right? That's a positive correlation. A negative correlation, this example might not be quite as great because we're in an online learning environment, but generally speaking, class attendance and final grade tend to have a negative correlation in that the more classes you miss, so as number of classes missed goes up, grade goes down. They're moving in opposite directions. That's what a negative correlation is. So it has nothing to do, there's no judgment there. I mean, there's a little bit of judgment for me if you miss a lot of class, but the correlation itself is not being judged. It's that they're moving together or they're moving apart from each other. That's all it means. So a negative correlation. So if you see negative 0.75 and you see plus 0.33, the stronger correlation is negative 0.75 because the negative and the plus mean nothing in terms of strength. They just indicate whether the variables move together or they move apart. Hopefully that's clear. Again, no feedback, so I'm going to go with, yeah, sure, it is, totally, crystal. Okay, and so again, here's the point. The direction indicates the way the variables co-occur. Now, some of the research that we do by correlation that's, again, relevant to clinical that you might not have heard about in other classes is what's known as epidemiological research. And I would say overall this year, we've heard a little bit more about epidemiology, virology, everything to do with illness and infection and spread and rates, and because that's just what we're living through. But again, that's not typical. And so typically we don't know a whole lot about it. And so when we're talking about epidemiology, I mean, unless you happen to be like a public health major or aspiring to go on to get a master's of public health, then you'd be pretty familiar with it. So epidemiology is the study of the frequency and distribution of a disorder in the population. So it can, of course, be applied to physical health disorders. It can be applied to anything. But our domain, again, is clinical psych disorders. And we're going to focus on 3 factors. And I'm going to throw them all up and then sort of talk through each of them. Oh, I just crossed over my yellow line. I have a mark on the floor, and I promised Caleb I wouldn't walk over it, and boom, I did. That's what happens. So we've got the prevalence, which is the proportion of the population that has the disorder at a given point. So in very real 2020 terms, this is how many people in Alberta have COVID-19 at the moment. Okay, that's our proportion. And every day the government updates their website to tell us how many active cases there are and even breaks it down by region. Right now, Edmonton is not looking so hot. By the time you watch this, Calgary could unfortunately have retaken the lead. Calgary had the lead for a good long time there. The incidence is the number of new cases of the disorder in some period, usually 1 year. So if we were graphing, and again, I'm just sticking with COVID-19 because it's relevant. Obviously, it's not a clinical psych disorder. But if we were graphing out year by year, starting in the year 2015, we would look at this graph where 2015 would have 0 cases, 2016 would have 0 cases, 2017 would have 0 cases, 2018 would have 0 cases. 2019, we start to see some cases, right, particularly at the original epicenter of the disorder, which was Wuhan. And then in 2020, we see an explosion of cases, particularly in the US, which is probably why it's a good thing our borders are still closed with them. We've seen big spikes in several Western European countries, so in Italy, in Spain. We've seen spikes in South America. So the incidence, the number of new cases of the disorder in 2020 is going to be huge because, again, this is a new virus that we're dealing with. And then something else we've been talking about, or at least you've probably been hearing about for the last 6 months, are those risk factors, the conditions or variables that increase the likelihood of developing the disorder. So one of the reasons that we're all still doing this remotely is because we don't know. If all of you were sitting in class with me right now, I don't know who's at higher risk. And I certainly wouldn't want to take the chance that somebody in our class was an asymptomatic carrier of COVID-19, spread it through class, and maybe nobody in class is at risk, but they bring it home to a parent or a grandparent, or they go to their job at a care home and spread it there. So these are three factors, so prevalence, incidence, and risk factors, that are really, really important in public health. And again, epidemiology comes from the public health domain, but we apply it to clinical disorders as well, in large part because it guides what we're funding in terms of treatment, what we're funding in terms of research for different disorders treatments, and also what we can do for people who are at high risk. Okay, so knowing these features is important for treatment planning and prevention efforts. We know that people who have a first-degree relative with schizophrenia are at higher risk of developing any of our psychotic disorders. So whether it's schizophrenia, schizophreniform disorder, schizoaffective disorder, schizotypal personality disorder, schizoid personality disorder, all of those, they're at increased risk. Somebody who doesn't have a first-degree relative with schizophrenia is at lower risk of developing any of those disorders. So maybe we're going to start a program, a social skills program, for children who have a parent with schizophrenia, in the hopes that that might mitigate some of their risk. That if we give them some of the tools that they need, that might help prevent them from developing schizophrenia. So that's important for us to know. The prevalence and the incidence are important too, because that's going to determine a little bit of where our dollars go. So right now, healthcare spending across the world is responding to COVID-19. And a lot more money is going towards education about that, to distributing masks at drive-through restaurants. I have opinions about that. I'm not going to share them on this, but feel free to bring it up in a one-on-one meeting. To education campaigns, to handing out masks for public transit, right? We're spending money there because of what we now know about it. But that means that some of the money that might normally be spent on seasonal flu or on STD testing, right, and STD awareness campaigns is not being spent because it's being redirected. So similarly, I have a hunch, I hope I'm wrong, but I have a hunch that we are going to see increased rates of anxiety disorders following all of these lockdowns and quarantines and isolations, and depression as well as a result of COVID-19. It might be more important right now to take mental health dollars and be pushing them into those areas and away from something like schizophrenia, right? Substance use is likely highly on the increase, and with more dangerous substances, because the usual routes of getting substances have been cut off with border closures. Depression and anxiety, those are all increasing. This might not be a time where as much focus on maybe something like eating disorders is as important. People are actually not seeing each other. They might not be as focused on that. We know that eating disorders is in large part driven by other people seeing you, commenting on you, things like that, right? So that's where knowing these factors, the prevalence, the incidence, and the risk factors, help us direct what we're going to study, how we're going to treat it, and how much money we're going to put into it. And so that's why it's important for us to be aware of. Okay, when we were talking about case studies, I did tell you that we were going to talk about how we can actually do an experiment. So it's not just gathering data, because a case study itself is mainly just gathering data about a person, but we can actually do what's known as a single case experimental design. And a single case experimental design, participants are studied one at a time and experience a manipulated variable. So just think about that for 1 sec, because I need some coffee. Much better. Okay, so what we're actually doing here, so I'm just trying to think of the best way of describing this, because I have different ways, but we're going to go with this. If I'm doing therapy with someone right? And I'm not with the university, not with a research study, just me, my office, private practice. Someone comes in, they want to talk about stuff. I talk to them about stuff. How I work as a therapist is guided by my training, which is guided by cognitive behavioral and behavioral principles and motivational interviewing. And I have all of that stuff back in the back of my head. But in that moment, sitting with that client, I'm not really thinking about that. And I'm not really thinking, well, I should do this, and then if I do this, I do this. It's just sort of, yeah, we do it. Like, that's part of the clinical training. However, that means that if that person gets better, and someone says, well, what did you do with them? And it's like, I don't know, chatted, talked, guided, right? I don't have something formal. With a single case experimental design, we do have something formal. And what we are actually doing is setting up the study in a way that we only have the one participant, either because they have a rare disorder or we're trying a novel treatment, but we are going to have them act as their own control. And we do what's called an AB-AB design, or a reversal design. So the example I'm going to use, I had a client several years ago when I was working at a university counseling center who had a pretty moderate to severe case of trichotillomania. Part of why I like using this example is I just love saying trichotillomania. It just kind of like rolls off the tongue, right? So again, and you might be thinking, well, I've heard of that, what is that? That's when people pull their hair, right? So it is sort of linked, it's now grouped in the DSM as an impulse control disorder. We think there's an anxiety component, and so people often start, and I won't demonstrate by pulling my hair, but they often start with the back of their head where you can't, I mean, look at how much hair I have, right? You can't see if I pull a few strands here, you're not going to notice it. And it starts as a nervous habit, and they pull, and then they keep pulling to the point where they have bald spots. And then maybe they move on because someone has noticed, and they might start pulling arm hairs out, or plucking their eyebrows out, or there have even been cases where people pluck their pubic hair out. Okay, we're talking, Caleb's just like, whoa, didn't know we were going there today. Yeah, I'll take you places, it'll be fun. So people have, now this client, her big thing was her eyebrows and her eyelashes. That was what she would pluck at. And she really wanted to stop pulling her hair out, but like nothing was working. So and I did come up with what I thought was a great idea, which was wear a baseball hat. It's really hard to get at your eyebrows and your eyelashes when you have the brim of a baseball cap in front of you, right? So that was like my one good idea per client. That's all I get, right? That's the way it goes. So if I wanted to formally study whether that worked as an intervention, what I would have done is I would have said, okay, this week, I want you to just carry on like usual. And I want you to write down, though, I want you to keep track of how many times a day you're plucking, and like maybe take a picture on Monday morning and then a picture on Sunday night so we can see how much hair you have actually plucked out over the course of the week, right? We need some objective measures of plucking. So that's my baseline condition. Then I'm going to introduce my manipulation. My manipulation is you're going to wear a baseball hat. You're going to wear it when you're asleep. You're going to wear it when you're awake, right? I want basically, or even now, silly me, COVID era, those plastic visors that people wear, you try getting underneath that to pluck your eyebrows. Good luck to you, right? So, but in this case, this was pre-COVID. So you're going to wear a baseball hat. Same thing, Monday morning, take a picture, Sunday night, take a picture, and also try to record how often you're plucking. If I'm right, if wearing a baseball cap is an effective intervention, the amount of plucking that the client does the week that she's wearing the baseball cap should go down dramatically, right? And at the end of the week, whereas the first week, her picture on Monday had nice full eyebrows, by the end of the week, they were pretty thin. The beginning of the next week, they were pretty thin, but by the end of the week, they should be back, right, if she hasn't been plucking. So now I think it worked, but to be really certain, and this is the reversal part, I put her back into baseline. I say, okay, next week, take your hat off. No hat. What should happen is she goes back to those original behaviors. Maybe a little bit less because the hat isn't there and she's now spent a week sort of breaking the habit of always plucking. But we would expect, if I return her to baseline, that her plucking is going to increase again to almost the same level, if not the same level as it was before the intervention. Then I know that my manipulation worked. And then, because I'm a good ethical therapist, I put her back into the experimental condition and say, okay, so just keep wearing a baseball hat. And then, you know, sometime down the line, I get a wedding picture of her in a baseball hat on her wedding. No, that didn't actually. None of this actually happened. Well, I mean, it happened that I had a client with trichotillomania, and my idea was wear a baseball hat, but we didn't actually formally do that as an experiment. But that's how we do a single participant experiment. And we can actually call it an experiment because we are manipulating the independent variable. Most of the time, when we're in treatment, when I'm working as a therapist, I'll say to a client, okay, let's try something. Let's do a little experiment, but it's not an actual scientific experiment. When we're doing a formal ABAB design, it is. And we can actually say the manipulation worked because we put them back into baseline and then put them back into intervention. Okay? And then finally, last little point I want to make has to do with mixed designs. Mixed designs are something we see a lot in clinical research where we are using both experimental and correlational techniques. We can't always manipulate all the variables. I can't assign, if I want to do a study on people with bipolar disorder, I can't just tell people, you now have bipolar disorder. I can't give it to them, right? So we get what we get. We might be interested in gender differences. Well, I don't have a gender reassignment lab down the hall. I can't just change people's gender. So we get what we get in terms of how people identify. So that's correlational because we can't manipulate it, even though we think it might have an impact. And that's something that from both a psychology perspective and even more so a medical perspective, we're becoming much more aware of, that most medical experimentation, except if it was specifically a women's health issue, has been done on men. And we're realizing that women and men do not always present in the same way. So a lot of the research on heart disease was done exclusively on men. And what we're realizing now is, oh, we need to include women in those studies because there could be differences there. Those differences, though, between men and women and how they respond to different medications or how they present with heart disease, that would be correlational because we can't change someone who's a woman into a man. Right? Like there are certain things we can't do, there are certain things we can, but we might then use the same experimental method, but we might be interested in both, does the medication work, and does it work differently in men and women? So hopefully that makes sense. That takes us to the end of research methods, so that's the end of chapter 4. And next up, we will be talking about mental health services, legal and ethical issues, chapter 16.